please.
Yeah, thank you for nice introduction, and I appreciate to have this opportunity to speak at ICACS and JSACS joint symposium. Today, I will discuss the limits of life-sustaining treatment in elderly ICU patients from both clinical and ethical perspectives. Let me start with a brief case. 92-year-old male patient underwent right hemicolectomy due to cecal cancer. He had no specific diagnosed disease before. On the postoperative day 1, he just collapsed while ambulating to the restroom and developed PEA. And CPR was initiated, and after 3 cycles, ROSC was achieved. Then just imagine you are in the charge of the ICU, and now this patient is yours. Then what will you do? So who exactly are the elderly? Traditionally, we define older patients as those aged 65 and above, largely based on the typical retirement age in many countries. Within this group, the term very old or oldest old is usually reserved beyond individuals aged 80 and above. However, in geriatrics, this definition goes beyond chronological age. Geriatric patients are better characterized by the presence of multimorbidity along with advanced age. As patients reach 80 and beyond, they tend to become more likely to have complications, chronic disease progression, and a loss of independence. So this is important because it shifts our perspective from simply asking how old is he to a more meaningful question, how about his functional status? Let me put this into perspective with a few key numbers. Globally, we reached a historical milestone in 2020. For the first time ever, the number of people aged 60 and older exceeded the number of children under the age of 5. Looking ahead, by 2050, nearly 8% of older adults will be living in low and middle income countries. Here in Korea, the pace of aging has been extremely striking. Life expectancy increased from 62.3 years in 1970 to 83.6 years in 2021. That's a gain of more than 20 years in just half a century. This slide shows Korea's aging index. As you can see, the increase is almost striking. In fact, Korea is aging faster than any other OECD countries, and this rapid shift is directly translating into a growing demand for intensive care services for older patients. Looking at Korean ICU data, patients aged 65 or older now account for 34.5% of all ICU admissions. The mean age of ICU patients has risen from 71.9 years in 2007 to 73.2 years in 2017. This is not a future problem, and it is our present reality. Japan is facing very similar challenges according to data from the GPAD registry, which includes over 230,000 ICU patients. About 1 in 5 ICU patients is aged 80 or older. In this group, ICU mortality was just 5.6%, while overall hospital mortality reached 12.9%. Importantly, functional outcomes are also concerning. Only about half of the patients in their 80s and just 40% of those aged 90 and above were able to return home after discharge. So what makes elderly ICU patients different? Over the past 2 decades, geriatric conditions in the ICU have increased significantly. These patients often present with a complex of challenges, cognitive impairment, functional dependence, polypharmacy, and nutritional deficiencies. Taken together, these factors fundamentally change how we need to approach their care. To address these challenges in a more systematic way, the 6 M's frameworks has been proposed for geriatric ICU assessment. It consists of 6 key domains: mobility, mind, medications, multimorbidity, and what matters most, understanding the patient's values, goals, and advanced directives, and momentum, considering the course of illness and overall prognosis. Together, this framework offers a structured and holistic approach that goes far beyond traditional organ-based management. This brings us to an important distinction, aging versus frailty. Frailty is defined as a clinically recognizable status of increased weakness resulting from a decline across multiple physiological systems. But the key point is this: aging is universal, frailty is not. Even among patients with the same age, there can be striking differences in physical reserve. Frailty tells us how vulnerable they are, and that's why we need objective tools to assess frailty. So a large meta-analysis evaluated the clinical frailty scale as a predictor of ICU mortality. Overall mortality was about 90%, increasing to 24% in patients aged 65 and older. When stratified by frailty, the mortality is increasing according to the CFS. The message is clear: frailty is not just a concept, it is measurable and independent predictor of mortality. This concept also extends to the surgical patients. A large analysis of 2.7 million cases across 9 non-cardiac surgical specialties using nationwide data showed that the modified Frail Index is a consistent predictor of 30-day mortality, postoperative complications, and prolonged hospital stay. For those of us in acute care surgery, this is directly actionable. Frailty assessment should be an integral part of the preoperative evaluation in older patients. Now, this is where things become truly challenging. In patients with geriatric features, prognostic uncertainty is at its highest. For example, when an 80-year-old patient is admitted to the ICU with the predicted survival around 50%, that estimate is, in reality, no better than a coin flip. This uncertainty is a characteristic of this patient population. 2 landmark European studies have significantly shaped our understanding of very old ICU patients. The first study, including over 5,000 patients aged 80 and above, reporting 32.6% of 30-day mortality. Frailty assessed using the CFS was independently associated with mortality. Notably, acute admission had the highest and strongest impact on prognosis. The second study provided further validation in nearly 4,000 patients. Each 1 point increase in the CFS was associated with a 10% increase in 30-day mortality. So, just previous speaker, Dr. Kojima, already told us that, so how should we act when we cannot predict? So one practical approach is the concept of a time-limited trial. Instead of making a binary decision, admission to the ICU or refusing to admission, we define clear therapeutic goals, set a realistic time frame, and then reassess. For example, we will provide full ICU support for the next 72 hours. If the patient shows meaningful clinical improvement, we continue. If not, we shift to the focus toward comfort-oriented care. This structured approach acknowledges the uncertainty of prognosis while still giving the patient a fair trial of treatment. At the same time, it helps us avoid both extremes, premature withdrawal on one hand and prolonged non-beneficial treatment on the other. Let us now define life-sustaining treatment. Life-sustaining treatment is any medical treatment that artificially supports or replaces bodily function essential to the maintenance of life without therapeutic benefit. The types of LST decision is first, continuing treatment, second, withholding further new treatment, third, withdrawing ongoing treatment. These decisions are grounded in 4 core ethical principles: beneficence, the obligation to act in the patient's best interest; non-maleficence, the duty to do no harm, avoiding interventions that may cause more suffering than benefit; autonomy, respecting the patient's right to make informed decisions about their own care; and justice, the fair allocation of healthcare resources. So in theory, these principles are very straightforward, but in practice, especially in elderly ICU patients, they often come into conflict. Let me give you a simple example. An 88-year-old frail patient requests full ICU care, including ventilation and CPR. At the same time, a 45-year-old trauma patient arrives and only one ICU bed is available. Now we face in a dilemma. Autonomy tells us to respect the older patient's wishes. Justice asks us to allocate resources to the patient most likely to be benefited. There is no easy answer. So what matters is that we recognize this tension, making our reasoning transparent and avoid decisions driven by age alone. So we need the clinical judgment to recognize when aggressive treatment is no longer appropriate. In practice, we face two risks: over-treatment, providing burdensome interventions with little meaningful benefit, and under-treatment, withholding potentially beneficial care based on age alone. Both represent ethical failures. Ethical decision-making needs to be addressed at three levels. At the patient level, we should initiate goals of care discussion early, ideally before critical illness. At the team level, we build consensus through multidisciplinary discussions. And at the hospital level, we need transparent policies for resource allocation and triage established in advance. Ethics cannot be an afterthought at the bedside. It requires a system-level approach. Now let's look at the Korean context. The 2018 Life-Sustaining Treatment Decision Act provides two pathways: advanced directives made by competent patients and the family-based decision when no directive exists, requiring agreement among family members with physician guidance. This framework reflects a balance between the patient autonomy and family-centered decision-making. Here is a striking reality. According to the national research, only 33.5% of LST withdrawal decisions in Korea are based on the patient's own self-determination. The remaining two-thirds are family-driven decisions. This gap between the legal idea of patient autonomy and the cultural reality of family-centered decision-making is one of the most important challenges we face. It does not mean our system is broken, but it means our approach to shared decision-making must be culturally informed, not simply imported from Western style. Finally, let's take an international perspective. Across countries, there are three key differences. First, legal frameworks vary widely. From formal legislation in Korea, Taiwan, and England, and I think that for Japan, the guideline-based practice in Japan. Second, the role of the family differs. Family-centered decision-making is dominant in East Asia, while the individual autonomy is prioritized in England. Third, the difference between withholding and withdrawing treatment remains controversial in East Asia, whereas Western ethics generally considers them equivalent. These differences highlight several ongoing ethical challenges in each cultural context. So now let me just return to the clinical case. Then now what will you do for this 92-year-old patient with colon cancer? Actually, I continued aggressive treatment for him. Despite the intubation and ICU admission, the patient experienced 4 additional episodes of cardiac arrest again, each followed by successful ROSC. So we applied ECMO and CRRT on this patient, and after 8 days, ECMO weaning was done. Then after 2 days, he did no longer need CRRT. After 2 weeks after cardiac arrest, we could extubate him. After total treatment of 38 days, he could successfully discharge to home. However, after 3 months, newly developed liver metastasis was found, and the patient declined further chemotherapy and expired on May 2025. I am not still sure that I decided in the right way for this patient. Maybe ECMO and CRRT is too much for him, but then could I just stop further treatment for him? I still have no answer about this. So let me close with 3 take-home messages. First, access frailty, not just age. Frailty is a stronger predictor of outcomes than age itself. Second, in very old ICU patients, prognostic uncertainty is the norm, not the exception. accept this uncertainty and use time-limited trials to make structured, reversible decisions. Third, shared decision-making is the standard, but it must be culturally informed, integrating both patient autonomy and the reality of family-centered decision-making in East Asia. Thank you for your attention.